Bueno, buenas tardes.
Good afternoon.
Bienvenidos a todos.
Welcome to all of you. I would like to especially thank Dr. Ariarte and Alba Soto, the outgoing president of our association and the deputy president of the society, for having accepted this enormous paramount challenge. I'd like to thank the speakers and the special guests for having accepted this invitation and for sharing their knowledge with us. We want to generate bridges from the outlook of basic science and clinical approaches to build together concepts that have a positive impact on communities. We take advantage of this meeting to invite all the attendees to please participate in the next upcoming Congress that will take place between March 16 and 18th in Mendoza. You will find all information on the Congress on the Argentine Protozoology Society, protozoology.org.ar. You can already register and find information available there. Thank you. Ade, you are on mute. Please get started again. Okay, thank you, Fernanda. We will get formally started with the symposium that we have named Working Harder, Making Better Biology and Treatment of T. infections, T. cruzi infections. I'd like to thank our speakers, our guest speakers, for having accepted this invitation and, as Fer said, contribute their knowledge in this. I'd like to thank our partners and our special guests, even though they are not here, and they will participate in the knowledge that will be conveyed here. To all of them, thank you so much. And I would like to thank Catalina, with whom we have worked together in this symposium. To each one of them, thank you so much. As Mike had said, each speaker has 20 minutes assigned for their presentation. We will have 8 minutes for technical discussion. If for any reason the discussion takes longer than 20 minutes, this will be subtracted from the 8 minutes of technical discussion. So we have some time in order to be more flexible. Towards the end of the discussions and all 4 lectures, there will be some amplitude, some room in order to carry forward a broad discussion between the speakers or among the speakers and among the different people participating in the symposium. We hope it is a broad discussion on the concepts that we will be discussing. Each one of them allude to a different situation. How about the methodology? Well, there is simultaneous translation going on, so we'll give priority to simultaneous translation. Please raise your hand and a list will be put together. You are kindly asked to ask a specific question, question that is to the point, and also the answer from the part of the speakers should also be to the point, so that we can include as many questions as participants are willing to ask. Questions can also be posted in writing, and if there is no room for the written questions during the session, we will ask speakers to take care of replying these questions in writing so that everybody is pleased with the interactions. Having said this, towards the end, we will have 5 to 10 minutes towards the end where we will be concluding, and that will be time assigned to close the symposium. Having stated this, I'd like to give the floor to Catalina. She will introduce you to the first speaker. We are already in contact with the speaker to see, with the other speaker, to see what is happening. It might be some time zone difference. Kata, you can take the floor. Good afternoon to all participants. It is my pleasure to have Dr. Facundo Garcia Bursen. He's a pediatrician and a clinical researcher who was trained in Argentina and Canada. He has a degree from the Buenos Aires, Argentina University as a pediatric specialist. His training as a clinical scientist was in Toronto, Canada. He went back to Argentina to work as an independent researcher in CONICET in Ricardo Gutierrez Hospital, carrying out research on pharmacology of drugs for pediatric diseases, especially Chagas, pediatric Chagas. He has taken active participation in the design and implementation of clinical trials and also in prospective PK trials and in randomized clinical trials. He's also done work in basic research, in vivo and in vitro trials for drug metabolisms and for orphan diseases. He also has conducted research on Chagas in several countries. He's the head of the division of the Pediatric Clinic Pharmacology Department in the Western University in Ontario. His interests are now focused on clinical pharmacology of drugs for children and pregnant women. And he also focuses on pediatric diseases, especially for vulnerable and neglected populations. The mechanisms is behind drug resistance. Fortunately for us, Facundo has not set aside his interest in Chagas, and this is what he will be contributing. Thank you. Thank you for the invitation and the kind introduction. It looks or it sounds as though it was written by my mother. I will be discussing about, benzimidazole. We could talk extensively about the very few drugs that we have. The focus will be on benzimidazole. This will be an introduction for the coming lectures by Rick, Diana, and Faustino, who will be talking about treatment for Chagas disease in more detail. I have some potential disclosures to make. In the last 10 years, I was a consultant in many of the efforts to develop drugs against Chagas. I have no vested interest in any of these companies, nor do I have a professional relations. My opinions are mine, and they do not necessarily reflect that of my employer, cooperators, or my children, of course, people and organizations. I'm fully and entirely responsible for the things I will say. Some introduction that might not be all that necessary, but well, you know, it is caused by T. cruzi. The main mechanism of transmission is vectorial or through congenital communication, the mother, or intake orally, or organ transplantation and transfusions. There's plus 8 million infected people in the Americas. This is an enormous underestimation, considering that there's at least 4 million infected people in Mexico. You know, the rate of people infected is close to twice as what is expected by PAHO, and there's estimated 50,000 yearly deaths because of the chronic conditions. Economic losses produced by this disease are beyond calculations, but the estimation a few years ago was $6 billion a year in losses associated to early death and, lost time at work. I should say that infection by trypanosoma is a pediatric infection, and Chagas disease is a chronic disease in adults who got infected being children. Therefore, we have to consider how to treat children, and that is important. Available drugs continue to be too, regretfully so. In the last 50 years, this has not changed. Benzimidazole and for Timox, there have been attempts to develop new ones, but none has made progress to a massive stage for use, even though there are some possible candidates. The treatment of Chagas disease, as I said before, is basically based on the use of benznidazole and nifurtimox. They are effective in an acute setting for pediatric infections. Effectiveness in adults when chronically ill is still doubtful. How effective are they, and who is to be treated when adult? Toxicity is frequent in the adults, and it depends on age. It is age dependent. Adults tolerate drugs far worse than children, and younger children tolerate drugs better than older children. Adverse effects, nausea, vomiting, malaise, anorexia, and weight loss, especially with NFX and adverse effect of hypersensitivity, such as rash on the 9th day and severe hypersensitivity reactions such as stress and Stevens-Johnson's syndrome are more frequent with benznidazole. But, there are systemic reactions such as Stevens-Johnson's and eosinophilia. They are quite rare. They are kind of a bogus man to avoid treatment, but in practice, they don't seem to be more frequent when being treated with sulfas or any other drugs such as carbamazepines. And a current problem is availability is erratic. I'm talking about availability of these drugs in pharmacies or to have access to treatment. It is erratic and it depends on political, geographical factors. Not all regions in some countries have access to these drugs in a consistent manner. And this makes it difficult not only to have access to treatment, but the persistence of the idea of treatment in the minds of physicians that have to prescribe it. If there is a drug available for 1 year, but then it disappears for 2 years, well, people or doctors find it difficult to have in mind the idea that this drug will be available or that it is a therapeutically viable option for a patient. Maybe an important problem with treatment is also related to what I said before, high resistance against its use by the healthcare system. It is quite common, especially considering the basic aspect. General practitioners, family doctors, and internists have the first contact with patients, and it is not common that they should feel comfortable administering this type of treatment, partly so because of a wrongful perception of risk and futility. During a long time, the key explanation as to why patients with Chagas are not treated is because the treatment is futile. This is not accurate, especially not in pediatric age. The pediatric treatment is effective and is related with far less adverse effects than adults. Treating children prevents toxicity of the child when becoming an adult. If we would to postpone the treatment for adult life. We have shown it, we showed it a long time ago when we reviewed adverse effects in the pediatric population, and we found that these events have less incidence in younger children as compared to older children, and especially as compared to adults. It is less toxic to treat a 3-year-old one than an 11-year-old one or a 20-year-old person for that matter. Therefore, there are not that many excuses to further delay treatment of a child with Chagas. And if Jaime would be delivering this lecture, he would say that not treating a child with Chagas would be malpraxis. I agree with that, because if we reject treatment, we prolong heart damage and we increase toxicity when being treated as adults. This is a repetition of what I've said already. Benznidazole was approved for generalized use in countries with only 2 trials with a total of 14 volunteers, and this was all the evidence that was accepted in the 1970s for approval. The dose defined at the time, 5 to 8 mg per kilo per day, based on cultures rather than on human studies. And during treatment, the duration of treatment and the dose were based on the opinion of those who conducted the development of the drug initially, rather than on major clinical trials, as would have been. Luckily, these doses are effective. We continue to use them because after long trials, they continue to be the best doses and the best durations. But the discussion as to whether to treat 30 or 60 days or 50 days, as Faustino will say, were up until not that long based on opinion rather than on adequate clinical data. Luckily so, there are some trials such as Bendita that shed more evidence, but the number of patients studied, especially with duration and alternative doses, are quite limited. The pediatric dose initially was adapted from adult dose. We took the adult dose. This was divided by weight, and we started using it for pediatric patients. Luckily so, this didn't yield any serious problem. It could have happened though, and the pediatric dose is the same that has been used for long years. But we now have PK trials that show that this dose is quite accurate and correct. To benznidazole treatment, well, this is associated to eternal doubts, and we won't be able to solve many of them or ever at all. The maximum tolerated dose is a doubt and a discussion that will never end. There are some who say that we should not use more than 300 mg or 400 mg a day. None of these limits is truly based on very many clinical real data. It remains clear that if you exceed 400 mg, toxicity seems to be far bigger or greater, but there is no conclusive trial as to say whether 300, 400, or 200 mg a day should be the maximum dose. The optimal treatment duration has been discussed for quite a long, but in order to give it a clear understanding, when benznidazole became to be used, it started being used for 30 days. Then it was used for 60 days based on trials in Brazil, but it was an investigator's call. It wasn't based on any PD trial. You know, Nifortimox was initially used for 20 days. Now it's been used for 60 days. And that change, that switch, is not based on any clinical or PD trial. It was just based on the opinion of the investigators who decided to go for the change. Benznidazole has to be adjusted in renal failure or in hepatic failure. There is no knowing. There are reasons to think that they should be adjusted in liver failure, but there are no reasons that would make us think that it should be adjusted in renal failure. There are no such clinical trials. That is quite calling, having treated thousands of patients already. And what about patients with altered PO absorption? That's a problem, especially in patients who have encephalitis because of HIV plus Chagas, where the PO route of administration is not the right one. And, the arrival of the drug to the CNS and to the blood flow is indispensable to save their lives. We have carried out a small trial with Dr. Marisa Fernandez. We have found that absorption is highly erratic in these patients, and the arrival of the drug to the CNS is very erratic. This bears a big consequence. If benznidazole doesn't reach the central nervous system, we cannot cut Chagas from the patient. The optimal route of administration is in discussion and should be in discussion for a long time. Originally, these were used twice or 3 times a day for no reason. This results from an analogy with the antibacterial treatment, where we have a stable consolidation to kill bacteria in circulation, but the parasite is not in circulation, and we do not need to have a persistent circulation because the cycle of the parasite is not that of E. coli or anything else. Once, twice, or 3 times a day, because treating with 1 daily dose should be enough, and we won't need to administer it more than once a day. The ratio between the antibody curves and the true response to treatment, by these I means, the elimination of the parasite and prevention of the risk of cardiovascular complications. This is the goal. Avoid patients from having Chagas cardiomyopathies over the long term. The real prevention of cardiopathy or prevention of complications in target organs, and the response that we use, which is the drop of the antibodies curve and the negative result in the PCR, are not that clear. We need long-term trials. For 30 years, we've been claiming so. Had we done one 30 years ago, we would have the results right now. The problem is to get the funds to carry out trials with this duration and for someone to be patient enough. But the problem is all investigators in Chagas understand by treatment response that is not truly the true answer that clinicians or patients are interested in. Bringing down the curve of antibodies is not a worry for patients. They just don't want to have a cardiomyopathy in 10 years' time or in 20 years' time.
When we talk about PK, we talk about absorption, distribution, metabolism, and excretion. There are many aspects here that can be seen in this graphic example. Benznidazole is absorbed in this way. We do not have an IV formulation. This would be important, especially in very small babies or those patients, they don't have a viable pathway, for example, with myoencephalitis. I am sorry, I cannot hear the speaker. I think, no, we cannot hear the speaker.
Ahí volvió, sí, ahí volvió.
Bueno. Perdón, un segundo. Creo que... ¿Mejor?
Can you hear me? So with the digestive tube, it's absorbed into the circulation and there it's distributed to the tissues. And I will just mention this briefly. It goes back into the blood and it is metabolized. BNC is metabolized extensively, especially in the liver, possibly in the digestive tube because of the flora. After it is metabolized, it is eliminated through the kidney. There have been discussions regarding the distribution in the tissues, but what we're interested in, we're not sure how good that distribution is. For example, the central nervous system, it's different and it varies depending on whether the patient has other factors that could affect this blood-brain barrier, and it's very important to take this into account when patients are immunosuppressed or when they have HIV disease. Absorption is something that we know pretty well, but we cannot know the real availability of benznidazole, but in studies in dogs and other animals, it seems as if this were an important parameter. There aren't any relevant drug interactions. We do not have evidence of how well it is absorbed, but food doesn't seem to affect absorption. So if benznidazole is taken with or without food, it doesn't seem to make any difference. There is some evidence that indicates enterohepatic circulation. And what does this mean for the treatment? This is yet not clear, but it is possible that with patients in the digestive tube, the concentration of benznidazole could be affected. There is also evidence that part of BNZ is eliminated in the fecal matter. There aren't many studies of bioavailability. There are some, that were studied, but the one conducted by the FDA did not analyze the fecal matter, and it is something to study. It's very important.
Parece amplia, al menos en los datos en animales. Uno puede hacer estudios en ratones y estudiar los tejidos. Es mucho más
We
difícil.
can study the tissues, but it's much more difficult, of course, to study humans and to study mice and animals. Roberts in the 80s did studies in oncological patients where samples were taken to study the central nervous system, and benznidazole reached the tissues in a very adequate manner, at least in that context. Metabolites seem to have access to the tissues, and there's also evidence of metabolism in certain tissues, especially based on animal studies. Benznidazole does not pass on to breast milk, at least if it does, it's at a minimum level. And so it's way below the indicated standard. So it's a very low percentage that is transferred to the breast milk. The idea of this of there being a passing through the placenta, there's no evidence regarding that, and also the risk of teratogenicity is only suggested by some animal models, but not all of them. There have been some accidental exposures reported in early pregnancies, but unfortunately, in those pregnancies, this is usually not reported. There is evidence that at the end of pregnancies, there might have been exposure, like, for example, and in the few cases, the babies were born without complications. The reality is that we don't have sufficient information about pregnant women. Regarding metabolism and excretion, metabolism of benznidazole seems to be mostly hepatic. There are multiple metabolites involved. We didn't know up to recently, we didn't know how many, but recent evidence suggests that there are many of them. In phase 1, after the step 1, there's a reduction of benznidazole. Then there are other steps in phase 1 that continue to modify the molecule, basically to make it more hydrosoluble. There is also significant evidence of stage 2 of conjugation with glycuronic acid and with cysteine directly. This suggests that maybe the elimination of metabolites can be accelerated by administering an acetylcysteine. And this opens up the possibility of dealing with the ribotoxicity, especially with patients who may have a lower amount of cysteine or glutathione in the liver, especially those who are regular alcohol drinkers. What are the exact steps? Facundo, I apologize, but you have 1 minute to wrap up. Thank you. I'm speaking very fast, but
Bueno, el papel de las enzimas metabolizadoras, sobre todo los citocromos, en el metabolismo del niacin no está claro en el momento. Hasta ahora,
there are many groups that have tried to identify enzymes that metabolize benznidazole. All the studies have failed so far, but there is some evidence that some enzymes may have some role, but it's still not clear what the role is. It is clear because we found conjugates with glycuronic, that the responsible for the conjugation of glycuronic acid has a role in the elimination of these metabolites, but which isoenzyme is responsible is still not clear. But it is clear that less than 6% of the doses is eliminated through the urine without being metabolized. So more than 90% of the dose is metabolized. There is an enormous amount of metabolites in phase 1 and phase 2 in urine, and many groups have described this to a certain extent. Carlos Pérez Montilla has been writing about this significantly. This is all unpublished material, so please don't distribute it, but this is some studies that have been conducted. Benznidazole is here, but all the rest are all metabolites in the liver. Maybe on the right, I would like to call your attention to all the metabolites, approximately 8, which are conjugated with cysteine or glutation. And this is what I was referring to, because maybe chronic patients could, with this element, could find it easier. They have to be conjugated with these elements, because if not, it will be only reactive, and this would involve a risk of liver toxicity. To conclude, I would like to mention that pharmacokinetics in children is different from that is found in adults, especially considering the fact that elimination in children is much faster. And this is shown in the studies. This is the response measured with qPCR, percentage of positive qPCR at follow-up. And basically this curve shows the concentrations seasonally. This is pediatric patients. On the right, we have adult patients, and we can see that this increases with age and reach the adult level approximately at the age of 11. But pediatric patients, although they have lower doses than adults, had concentrations that were adequate to eliminate the parasite and maintain the negative PCR throughout time. Adults treated with the same doses developed toxicity in a much easier way. I think I'm going to finish here. So basically, many of these studies reached or were part of the approval of benznidazole, especially in the process conducted by the FDA. I wanted to thank the people from the Children's Hospital here in Buenos Aires. I worked with them for a long time. Some of them I didn't have pictures, but I wanted to thank them especially Guillermo Moscatelli and Jaime Alche, who originally opened their doors so that I could work with them. And Carlos, who did all of the metabolic studies. Thank you. Thank you very much.
Gracias, Facundo.
Thank you very much, Facundo.
¿Alguien quiere hacer alguna pregunta?
Does anyone wish to ask any questions?
Hay una pregunta en el chat.
Ahí está.
Hay una pregunta sobre cuál es el citocromo que parece ser el
What is the cytochrome that appears to be the main metabolic pathway? Unfortunately, we are not sure about this. There is limited evidence in the laboratory based on the lab tests, which is the cytochrome 2E1 might play a role in this, but there is very limited evidence. And I think that this was the cytochrome that wasn't studied by other groups, so that's why we're focusing on this one. But to be honest, the evidence is just very, very limited. Not even in animals. The UGTs, the ones that conjugate these metabolites with a glutathione, for sure play a role, and glutathione transferase also plays a role because there are many metabolites that are conjugated with this component.
Luciana Soprano tiene una pregunta, si quieres hacerla.
Any questions?
Luciana.
Está silenciada, me parece, Luciana.
Sí. Bueno.
Cacha.
Adelina.
Facundo, o sea, en pacientes con HIV
patients with HIV, what is the certainty that the benznidazole doesn't cross the blood-brain barrier? It does cross that barrier, but we have some CSF samples that indicated this, but patients that were receiving a large amount of benzoyl did not show this. So I think that in certain circumstances, absorption is very bad, especially those patients with high levels of inflammation or that have a nasogastric tube. But the passage to the central nervous system is quite variable, to put it mildly, right? Those who have encephalitis, I think, should receive a higher dose. And I think that we should measure the concentrations in blood. I think it's not that difficult to do that. Marisa Fernandez was asking whether you would give N-acetylcysteine to a patient with adverse events caused by BNC.
Es difícil saber, yo creo que hay que hacer el estudio.
I think that the study needs to be conducted because there's sufficient evidence to justify such a study. I think that in those cases where you have no other options, you can administer this. But I'm worried about N-acetylcysteine and affect the response to the treatment. The parasite cannot conjugate with glutation, but this is a possibility.
No quiero decir más de lo que debería.
I don't want to say more than I should. I think this is a possibility and we need to study it and study it seriously.
Bueno, y pregunta Silvia Repeto, ¿cuánto tiempo recomiendas tratar la reactivación?
How long do you recommend treating parasite reactivations in patients that are not VIH patients, HIV patients, sorry? I don't know. I'm a pediatrician. In pediatric patients, you have to treat it 60 days because if not, there are other problems. I think in adults, it's much more complex. I think all the other specialists here are more qualified to answer this question.
Bueno, sí, entonces estamos en tiempo para
I think we're in the time to welcome Faustino.
Gracias, Facundo.
Thank you very much, Facundo. Faustino. Our next speaker is Dr. Faustino Torrico. He is joining us from Cochabamba in Bolivia. Dr. Torrico graduated from the Free University in Brussels, where he obtained a diploma in tropical medicine in the Tropical Medicine Institute in Amberes. He had a master's in public health in Brussels and then received a degree, a PhD. Since 1991, he develops activities in Bolivia as a professor for parasite and infectious diseases in Universidad Mayor de San Simón in Cochabamba. In that same university, he coordinates and is a teacher in the postgraduate course on tropical medicine. In Bolivia, he was responsible for the diagnosis and treatment in the National Program to Control Chagas Disease, and is currently a technical consultant in that same program. Since 2009, he has developed his activities in research and technological research in his country. His main areas of research are prevalent infectious diseases in Bolivia, such as Chagas, tuberculosis, and HIV, and is a specialist in epidemiology, focusing on congenital Chagas disease. He is currently the president of the SEADES Foundation. It's a science of applied studies for the development of health and environment. And he's also a guest professor in the Global Institute of Health of Barcelona. Dr. Torrico is the main investigator, the principal investigator in different studies, and is also considered a reference point for clinical research regarding Chagas disease. He has participated in several clinical trials evaluating new drugs focusing on chronic Chagas disease. These studies have been published in high impact journals and have been vital to promote other clinical trials in Chagas disease and other neglected diseases with scientific rigor and a high level of evidence in our region. Dr. Torrico will be presenting for the Bendita and Teseo studies. Go ahead, Dr. Torrico, you have the floor.
Estoy buscando mi presentación, perdonen.
I'm looking for my presentation. For some reason, I cannot see it.
Aquí está. Perdonar.
No hay problema, Faustino.
Bueno,
I apologize. That's all right. Don't worry. I'd like to thank the Argentine Protozoology Society. I would like to thank Dr. Adelina Riarte, Dr. Catalina Alba for this invitation. It is my big honor to be present here in this presentation. I will discuss about some trials, some tests that we have conducted and continue to conduct in Bolivia based on the two drugs that are available. Facundo has talked about them very clearly indeed. He talked about benznidazole, especially. We carried out a trial on benznidazole and one that is underway with a combination of benznidazole and nifurtimox to treat chronic Chagas disease with adult patients. So I will specifically talk about Chagas disease, and I might attempt to answer one of the questions that were posted. It is important to say that, the history behind treating chronic Chagas hardly dates back to 2002, when its use for chronic Chagas was authorized. It was used before for acute Chagas, and this came about from a report from the Committee of Experts of WHO in 2002 that says, it has been recently agreed on the fact that patients with chronic Chagas disease have to be treated with parasiticidal drugs. Given the epidemiological realities of each country, an agreement was established on the fact that people with a positive serology for Chagas should be treated with specific drugs. So you see the authorization to treat chronic Chagas that doesn't have more than 20 years history behind, even though some groups were treating them nonetheless. Against this backdrop, I would like to talk about some history and the grounds where the two trials that I will be discussing in more detail are based on. Chagas disease affects between 6 to 8 million people, keenly in Latin America, but due to migration of people, we might find it in other places such as Mexico, United States, Canada, Europe, Asia, Australia, and other regions. We should know that currently less than 1% of people who are diagnosed are then treated. I talk about chronic Chagas. Approved treatments currently, as Facundo already showed, are benznidazole and nifurtimox. These are drugs that date back to the 1970s. Efficacy of both drugs is variable, and it is dependent on a number of factors: the disease stage, the drug dose, the age of patients, the strain or T. cruzi genotype. The therapeutic failure that has been seen so far in chronic patients happens in at least 20% of patients when we follow up on them with molecular biology at 12 months. There's high rates of adverse effects between 10 and 27% of treated patients. And of course, this is according to each one of the trials. Treatment duration, well, it was very well explained that it is not yet clear the duration of treatment. We have assessed it in a systematic manner, and current treatment schedules and dose intervals, as Facundo stated, are not all that clear. Whether once daily, twice daily, or 3 times a day. And out of all of this, we do find the need to have safer treatments because there are adverse effects, major adverse effects that can be found. We need to have more efficacious treatments and also the availability of early therapeutic efficacy biomarkers. So this is how we are going into the first trial that we have conducted. It has already finalized and it was published. We called it Bendita, new benznidazole schedules as monotherapy and in combination with fosravuconazole to treat Chagas disease. Even though due to the limitations of time, I won't be talking about fosravuconazole, but it was part of this trial. In this trial, Bendita, we had a total number of 7 arms, 7 branches, 4 of them with BZN2 combined with benznidazole, with E1224 and placebo. All 4 arms of benznidazole we will be referring to, we have the standard schedule, 300 mg a day in 2 doses for a week, for 8 weeks. We then have the second arm, 300 mg a day, again for 4 weeks, twice daily. We have the benznidazole arm, 300 mg for 2 weeks only, and the final one, benznidazole, 150 mg a day in 1 single dose for 4 weeks. And well, of course, we have placebo as well as negative control. This is the study design. This study was sponsored by DNDi, and the counterparts were the CIADES foundations with the platforms that have been developed for the treatment of adult onset Chaga in Cochabamba, Sucre, and Tarija. We also did it together with IS Global from Spain, Barcelona, Spain, and Injebi, you are well familiar with. These are the 4 arms. Actually, it's all arms that had been entered in the trial, the standard dose, and here placebo was used, that is E1224. We then have the other 3 arms, the ones to do research on 300 mg of benznidazole for 4 weeks, for 2 weeks, and 150 mg of benznidazole a day for 4 weeks. Here we have combined arms with E1224, and here another arm with E1224, and this is based on benznidazole once weekly. And finally, placebo. So treatment, the maximum duration was 2 months. This was done in adults between 18 and 50 years of age, all of them in an indeterminate chronic phase of Chagas, with a total of 230 subjects with 30 patients per arm. You see, these were not all that many patients, and there was a follow-up on them at 10 weeks, 12 weeks, 4 months, 6 months, and 12 months. Total follow-up, but it was basically based on results of PCR. And here we have benznidazole arms. 518 patients were screened, out of which, we chose 210 who were included, and they got assigned to the various groups on a 30-patient basis. In the case of the standard treatment of benznidazole, out of 30 patients, 24 concluded the study according to protocol. 6 of them, for a number of different reasons, discontinued due to adverse reactions. In the case of the 4-week arm of benznidazole, 300 milligrams, 2 patients discontinued, one because of a severe adverse reaction and the other one because he withdrew consent. So out of protocol, we ended up having 28 patients In the case of benznidazole, 2 weeks, 28 patients finished. One of them was discontinued because she got pregnant, and one because there was a deviation in inclusion-exclusion criteria. And finally, as can be well imagined by you, in the group of placebo, 30 were admitted and all 30 finalized their participation. Here, we should see the PCR results and some comments in connection with adverse effects of these treatments. You have a PCR by protocol at 6 months and at 12 months. And all 4 groups of interest here, well, the figures or percentages are give or take the same, 86, 88, 82, and 86. 82 in the case of 2 treatment weeks. And as to placebo, as you can see, one was consistently negative throughout the duration of the trial. And at 12 months, you can see that the figures remain pretty similar. Percentages have no statistical significant difference among them. And in connection to adverse effects, well, you know, adverse effects showed that arms with benznidazole for 2 weeks had no adverse effects. In the case of benznidazole, 4 weeks at 150 mg, well, there's one case, and you can compare with percentages what was seen in the 2 against what was seen in the 2 previous arms. This in the blue bars, we find efficacy, and you can see that there is no major difference among the various groups. In connection to compliance to treatment, almost all patients had very good compliance. You know, in a trial, compliance is always very high. And in connection to safety, we had some issues with the standard dose and also with the combination dose with E1224. The take-home messages from this trial, all the treatment arms showed superior efficacy as compared to placebo, luckily so. The primary efficacy criteria at 6 months and sustained parasitologic elimination or clearance at 12 months. No patient canceled treatment due to an adverse effect related to treatment in the benznidazole arm with 300 mg at 2 weeks. Short duration schedules showed a very good safety profile with a permanent interruption rate of 0 in the first case and of 3.3%. That is one case in the second one. The use of fosravuconazole, even though I didn't present anything in connection to this, but in combination with benznidazole, does not significantly affect efficacy. There's nothing to comment about this. All treatment arms had a very good compliance rate, which is only commonsensical because there is a selection as pre-screening and a screening of patients. And of course, we keep monitoring and following up on them. We never lose contact with them. Our results suggest that alternative benznidazole treatments with shorter treatment durations and lower doses keep similar efficacy than with the current standard schedules with a higher safety for patients. We believe that reducing the standard treatment schedule of 8 weeks of benznidazole to a shorter schedule that lasts 2 weeks could largely simplify treatment of Chagas disease and contribute to better compliance on the part of patients. Of course, it is easier to comply with treatment for 2 weeks than for 2 months. Let me now present a trial that is going on, which is TESEO, New Schemes of Chemotherapy and Biomarkers for Chagas disease. I will only talk about the recruitment, patients recruitment, because this is a trial that is ongoing. Additionally to the background information that we explained before that give grounds to the trial. Well, here we should say that recent data show that there is overdosing of patients with benznidazole. Chances are that they also are overdosed with nifurtimox, and with half of the frequency, benznidazole levels can remain in the therapeutic range. This could reduce the emergence of adverse effects, keeping antiparasitic efficacy. And we are planning to assess whether the drug efficacy shall remain and whether safety will improve if the duration of treatment with benznidazole or nifurtimox is cut down to 30 days rather than the 60-day standard dose. We also consider whether efficacy of treatment with benznidazole and nifurtimox could improve by increasing its duration to a total number of 90 days. We also consider assessing potential biomarkers derived from the host and from treatment in order to assess a parasitologic cure in patients with chronic Chagas disease. This was done in the very same sites that I described before, that is in Cochabamba, Sucre, and Tarija. This is sponsored by the Texas El Paso University. It is a phase 2 open label randomized prospective observational study with 6 parallel arms. And the study drugs that were used here are benznidazole and nifurtimox. We said that this was conducted in Bolivia in areas with an ecology and similar altitudes, districts Cochabamba, Tarija, and Sucre, that share similar characteristics. These are the treatment arms, and here we include 450 patients, 75 patients in each arm. So we are doing this with a greater number of patients. The arms are benznidazole 150 mg twice a day during 60 days. This is the standard arm, benznidazole 150 mg once a day for 30 days. Again, 75 patients, benznidazole 150 mg for 90 days. Again, with 75 patients, and we also included 3 arms with nifurtimox, 200 mg twice a day for 60 days, 200 mg twice a day for 30 days, and 240 mg every day, 1 single dose a day for 90 days. This is the study design. It is a relatively complex trial. After all the data that have been entered, we know we monitor this regularly on patients. An important thing, one of the fundamentals of this trial, the rationale, is this 3-year follow-up of patients. So this is the great variation, as with Bendita, where follow-up was only for 12 months. This leads to some questioning of the validity of results. Here we are following up on patients in a systematic manner and in a repeated manner, considering clinical and laboratory findings and biomarkers during 36 months. Endpoints, for primary efficacy assessment, parasitologic sustained eradication determined by qualitative consistent PCR. This is done towards the end of the treatment at 4, 6, 12, 18, 24, 30, and 36 months of follow-up. And efficacy evaluation criteria, we carry out PCR with the same guidelines that were mentioned before, but we will also see the serological conventional and non-conventional responses and changes in biomarker levels over time.
Adversos severos y no severos que podrían conducir a la interrupción del tratamiento y la gravedad.
Here we see the different severe adverse effects that could lead to the discontinuation of the treatment, and both from a clinical perspective and also in a laboratory and in terms of the ECG. The levels of BZN and NFX will be quantified through liquid chromatography, high resolution liquid chromatography. So this study, unfortunately, began in the middle of the pandemic. And as you can see, in December 2019, we started the recruitment. It went pretty well at first, but unfortunately, in March 2020, we had to interrupt, practically for 5 months, interrupt our recruitment completely. We did follow up on the patients, and we resumed in September 2020, and in April 2021, we had recruited the number of patients that we needed. All of them have concluded their treatments, and they are currently under follow-up. One is a 6-month follow-up, another one is a 12-month follow-up, and soon we will have 18-month follow-up completed. Thank you. Thank you very much. Thank you very much, Faustino. I truly appreciate your presentation, and thank you for sharing all of those insights. I have 3 questions that have been asked. Let me ask them to you. Luciano Lima is asking, good afternoon. We are still without a recommendation that discourages the treatment of chronic patients to avoid chronic complications. Well, I think that the WHO indicates that chronic patients need to be treated when they have positive serology and Chagas disease. This is a very strong recommendation. The problem is that many doctors fail to learn in a way. There are many Latin American doctors in Europe, and in Europe, they don't really they don't really go by recommendations. They go by the guideline that indicates that they need to treat. And each doctor is going to decide, for example, if there's no cardiopathy because of Chagas, the treatment has the goal of avoiding the appearance of cardiopathies, right? And so if we fulfill those requirements and we do good medical surveillance, because these 2 medications have a high level of toxicity, I think that their recommendation, if we follow it, it's very clear. Dr. Janice Leslie is asking, could you indicate when the adverse effects appeared in relation to the beginning of the treatment? Because the literature indicates that these appear in the first 10 or 12 days. The observation that we have, particularly in the study, in the Teseo study, almost all of them appeared before 15 days. Almost all of the adverse effects. This is quite similar in all cases. We have both in the case of benznidazole and nifurtimox. It's the same, 15 days. Dr. Janice Leslie is also asking, in Teseo, do you do PK? Is there an intention to evaluate cardiac parameters? Yes, we do PK systematically. And with the protocol that was developed together with Spain, we are taking all of the samples, and these samples will be sent to Spain for their to be analyzed, both in the case of benznidazole and nifurtimox. Okay, Valeria Tequiel, congratulates you for your work and asks, which are the biomarkers that will be evaluated? The biomarkers, let me be very clear. Many of the biomarkers have been developed during the time of the evaluation, yes, during the time of the study. And even now, since this is a new topic that is under development, even now, we are still discussing the issue of biomarkers. What we have done is to take samples and to conserve them, because biomarkers, well, it's a very long list that could change at a certain point, depending on how technology advances. Let's see, there is someone who raised their hand before, Dr. Botasso. I don't know how we're doing with time. If not, we can answer your question later. We have 3 minutes. We have 3 minutes for questions. Okay, so let me go back to the question asked by Dr. Botasso. Sorry, I cannot see the question. I can read it. I can read it. Okay. Thank you for the interesting presentation. How feasible is it to continue studying the participants of the Bendita study outside the first year? And the second question is, what is the level of beta errors that this second trial has, the Teseo study? In regards to the follow-up of Bendita patients, the sponsor was the NDI, and we've tried to do follow-up after the study, because of course this is a fundamental question, yes, and it's very important to follow up on it, but we haven't been able to approve the protocol. We do have samples from a group of those patients, and considering the fact that patients who underwent this treatment and were positive at the end of the treatment using PCR received a rescue treatment. So unfortunately, right now, it is not possible to recover or to rescue those patients to do more follow-up, except for those that we have in our database, and also those blood samples that we have for PCR. Regarding the level of beta error or the margin of error, I'm not a statistician, and I do not have my statistician next to me. He's the one who knows exactly about the margin of error, so I cannot answer that question. Cata, can you enable the audio for Dr. Janis, because he's asking a question as well? His microphone is enabled now. Yes, go ahead. What a pleasure to see you, Faustino. Thank you very much. We're very happy to see you still in this study. Regarding the Bendita study, when I asked about when the collateral adverse effects appeared, you clarified that it was between the first 15 days, between 10 and 12 days on average. But you said that there were more adverse effects in the groups that had a long treatment, but it doesn't matter in which arm they are, right? There is no difference in terms of safety. I mean, the adverse effects appeared the same at the same time for all arms. That is right, but that is something that we needed to analyze. But in the group that was 30, 60, or 90 days, the adverse effects occurred within the first month, yes, much more often in the first 15 days after the beginning of treatment. So yes, I do agree with you, and these adverse effects are associated with the initial toxicity of this drug. Okay, very well. So one cannot say much about the differences between a short-term treatment and a long-term treatment. One cannot say that a long-term treatment shows different adverse effects, because all of them appear at an early stage, right? One cannot make that claim. Right, it is within 2 weeks. In the case of Bendita, we had 0 adverse effects. So is this random? Is it consistent in the study? We do not know, but that's what the study showed. And in the 4-week treatment with benznidazole, we had 1 out of 30 patients who showed adverse effects. So obviously, well, the results speak for themselves. And with the Teseo study, what we're seeing is that most of the adverse effects, regardless of what regime they're under or what type of treatment they're all occurring within the first 20 days. So if within the 21st days, depending on the different doses, the same adverse effects appear, then probably what we need to study is the efficacy of the treatment. Yes, how long the PCR remains negative, in this case, up to 3 years. Okay? Okay. Cata, I think we should move on. Thank you very much, Faustino, for your presentation. We will continue at the end with the discussion. Thank you very much.
Good afternoon. We are very pleased to have you here, Dr. Tarleton. Dr. Tarleton doesn't need further introduction to this auditory anyway. He's a Regents Professor and Distinguished Research Chair in Biological Science at the University of Georgia, Athens, in USA. He was the founding director of the Center for Tropical and Emerging Global Disease at the University of Georgia, currently home to more than 25 labs working in the area of tropical parasitic diseases. Both his BA and PhD degrees are from Wake Forest University, where he fell in love with Trypanosoma cruzi under the mentorship of Ray Cohn. He has worked nearly exclusively in the area of Chagas disease, including studies on the mechanism of immunity and disease in T-cruzi infection and the development of diagnostic, therapeutics, and vaccines for this protozoa. His lab provided some of the seminal findings documenting parasite persistence, insight into the function of CD8 T cells in immune control, and multiple tools for the study of T. cruzi, and most recently, adaptation of CRISPR-Cas9 system for genome editing. Among current projects in his lab are a better general understanding of the host-parasite interface, with a focus on how parasite biology impacts host response, discovery of biomarkers of cure in humans and animal models, and the development of improved regimens and discovery of new drugs for treating the disease. Dr. Tarleton is the founder and president of the Chagas Disease Foundation, former chair of the US NIH Immunity and Host Defense Study, and founder and convener of the Chagas Drug Discovery Consortium. Today, he will share with us observations from his lab that pose a challenge on treatment efficacy. Welcome, Dr. Tarleton.
Thank you very much. Thanks for a
Welcome.
nice introduction.
Welcome, doctor. Let me just interrupt you a second. Would you mind stopping your share and resharing? Because it's cut off.
Okay,
It's
sure.
cut off in Zoom. Thank you.
Let's see about that. Is that better?
Perfect. Thank you.
Perfect. Go
Okay.
ahead.
Thanks again for the introduction. My apologies for joining a little late. I had my clock wrong. Daylight savings time has tripped me up here, unfortunately. So I'll try to make up for time here. What I'm going to try to talk about today is the sort of the interface between parasite biology and how that impacts how we choose to treat patients with Chagas disease in terms of how we use drugs. And let me see, here we go. So basically, first I want to point out that I'm not trained as a clinical drug administrator or as a drug design or drug discovery person. That's not my training. But I've kind of gotten drawn into this field in understanding how the biology of the parasite may determine how we use the drugs that we have access to. And in doing that, I've sort of come to know how the drug discovery and drug treatment system works and how this may clash sometimes with parasite biology. And by that, I mean, in designing drug treatment protocols, generally the protocol is to identify compounds that rapidly kill most organisms, most emphasize there because most drug discovery protocols intend to identify things that kill, but don't generally look at every single organism being killed, especially in vitro. Then determining the minimal effective level or dose of use of that drug, that's usually determined in vitro. Then to dose in vivo so as to maintain that level in the blood at least. And then to continue dosing until a subject is cured, and that's usually determined empirically. And this works for a lot of diseases and a lot of treatment protocols, but there are a couple of things about the biology of some pathogens and how some drugs work that don't allow these simple paradigms to always yield the right outcome. So one of those is that not all organisms in a population are equally susceptible to a drug. And I'll talk about dormancy in particular, but there are other cases where there's genetic variation that makes a subpopulation of pathogens less susceptible to a particular drug. The other issue with most drugs is that they are not, that not all tissues and all sites in the body are equally accessible to a drug. And this is not a problem with many pathogens that isolate to a particular tissue, such as influenza in the lung, for example. But it is a problem with a parasite like D. cruzi that can be in multiple different tissues throughout the body and tissue types. And so I'm going to talk about these two things and how this may impact how we treat with drugs Chagas disease. And first dealing with this issue of dormancy. And we first became interested in this and trying to explain this phenomenon that we have observed where, again, using benznidazole, and here I'm going to show you a number of experiments where we use reporter parasites, in this case, ones that are expressing a luminescent protein that allows their detection by luminescence, in this case in the foot pad. And then in this case, we're injecting parasites in the foot pad and then giving a single dose of benznidazole orally 2 days later, and then following that over the subsequent 48 hours. And what you can see is a dramatic decline in parasite numbers over that 48 hours, a 90% or so decrease in parasite load. This is with a single oral dose of benznidazole, but in this same model, we can give this same dose daily for 40 to 60 days in some cases and fail to cure the infection. So why is it that we can kill the majority of parasites with a single dose in a very short period of time, but not over a longer period of time, giving that same dose over and over again, not be able to cure the infection? And the first hint for us came from these sorts of experiments, which were washout experiments, where we would treat infected cells in vitro with a high concentration of drug. This is 50 times the IC50 of benznidazole in vitro, wash out the drug after certain treatment times, and then watch for the re-emergence of parasites in that culture. And essentially what we saw is washout experiments going as long as 30 days of drug treatment. We could still detect parasite outgrowth. So keeping a high concentration of drug on parasites for 30 days still did not clear these cultures, was not killing all the parasites. And I'll come back to this issue a little bit later. And finally, we started to look at this by microscopy and using, and this is another model I'll use repeatedly, is reporter parasites, in this case, expressing the fluorescent protein TD tomato, and then pre-stained as trypomastigotes with cell trace phylates. And the cell trace phyllate gets diluted as these parasites replicate, but some parasites don't replicate and therefore don't dilute the dye. And you can see this one parasite in this particular cell. While the other parasites are dividing nicely, this cell trace phyllate positive parasite has not divided. And we can see this sort of phenomenon in vivo as well. It's very difficult to do because finding single dormant parasites in an animal, in this case, after benznidazole treatment, it's not simple, This is looking in the fat tissue and seeing these dormant parasites, again, identified by the retention of the cell trace violet. So what do we mean by dormant? And that's something that we've investigated. We are investigating quite vigorously, but without a huge amount of data. One piece of data here that I think is particularly interesting and important. One of the things we're trying to ask, so we know these parasites are not dividing, but what are they capable of doing? In this case, we're using a substrate, a fluorescent substrate for the nitroreductase. This is the same enzyme that activates nifurtimox and benznidazole. And what we can see in these amastigotes, these are extracellular amastigotes in this case. Again, same sort of situation, TD tomato positive parasites dilute the cell trace violet positive parasites retain the dye because they're not dividing. And if you look at the nitroreductase activity shown here, you can see that these few cell trace violet positive parasites really have very little enzyme activity as well. So they're not completely absent of activity, but they have much reduced activity. And this would support the idea that they're not activating the drug, and therefore they're not susceptible to benznidazole treatment. We'd love to have a lot more data about the metabolic activity of these dormant parasites. It hasn't been an easy thing to study, but we are actively pursuing that. The other issue besides dormancy that I wanted to emphasize was the second one about body sites and tissues being equally accessible to drug. And this is a particular problem with T. cruzi because it can infect so many different tissues and so many sites in the body. And I just have one piece of data related to that, and that has to do with the tissue distribution of benznidazole in mice. And this is given 100 mg per kg, which is a standard mouse single dose, and then looking 2, 4, and 8 hours in the serum, muscle, and fat. And the point I want to point out, I just showed you dormant parasites in fat, and what I'm showing you here is that the concentration of benznidazole that is reached in fat is substantially below that that's in muscle and well below that that's in serum. So there's not an equal distribution of this drug to tissue. And if you have parasites that are in fat, the IC50 of benznidazole is usually considered to be around 1 micromolar. At 8 hours, this is less than 2 micromolar in the fat. So the level of drug in the fat is quite reduced, and therefore, even if parasites are not dormant, this is not a concentration that's going to readily kill those parasites. So to deal with this issue of dormancy and also this issue of tissue distribution of drug, we started to think about how we might be able to use benznidazole somewhat differently. And this is an experiment that supported the idea of increasing the amount of benznidazole that we use in a single dose, but giving it less frequent, so the total drug exposure is not increased. And so what one can see here is using either the standard dose, 100 mg per kg with the mouse, or 5 times that dose in animals, again, using reporter parasites that we can monitor, parasites in the foot pad. And what you can see is that a single dose of 500 mg per kg can drop the parasite load down and keep it down for a number of days. So there's only a single dose of drug being given here and no more drug until 5 days later. In contrast, if one gives the standard dose that we usually give in mice, 100 mg per kg, again, it drops the parasite load well, but those parasites bounce right back up. So this suggests that an intermittent drug treatment where you're not giving the drug every day, but rather every few days might be effective in controlling parasites and getting drug better to all tissues because you're using a higher dose. So this is basically what we've tried to do with these intermittent treatment protocols to allow a higher treatment dose without increasing drug exposure. And then also this provides an opportunity for dormant parasites to exit dormancy. So one can extend drug treatment over a longer period of time if one needs to. Now, dealing with this dormancy issue again, there's a lot we don't know about dormancy. The things we do know about dormancy is that it is spontaneous, that it's not induced by stresses like starvation or drug treatment. It doesn't prevent parasites from converting between trypomastogates to amastogates and vice versa. And it is transient. And that level of the length of dormancy is really highly variable between various dormant parasites. And one can see that in this particular experiment. This is a culture of infected virocells in vitro, obviously. Again, we've got parasites that were staying with cell trace violet beforehand. One, if they haven't divided, they retain cell trace violet. Should look in particular at, if you can see my arrow right here in the middle, this group of parasites, you've got a few that are TD tomato positive that have divided, and a number of dormant parasites that have not divided. And if you follow these parasites for an additional 24 hours, what you can see with that set of parasites is that those dormant parasites have come out of dormancy and have started to divide. They're losing the cell trace violet. They've increased in number. And you can see that throughout the culture, although there are still cell trace violet positive parasites in this culture. So some parasites are coming out over a very short period of time. Some obviously take a much longer period of time based on the washout studies I showed you earlier. Another thing that's interesting that we've just started to look at, and that we think may have some importance in terms of this intermittent treatment, is that some drugs, and benznidazole is one of those, has cytostatic activity that prevents parasites from exiting dormancy. So what do I mean by that? Here we've got, in the same sort of culture, TD tomato positive parasites. This is, I think, about 3.5 days after infection. So these cells are very heavily loaded, and they have a number of dormant parasites in there, pre-stained again with cell trace violet. So you can see the dormant amastogates in this culture. If you treat this culture starting at about that would be 30 to 36 hours after infection for a day and a half, what you can see is that with benznidazole, you can see that you prevent and kill many of the replicating parasites. You actually increase the number of parasites that appear to be dormant. And basically, what we believe is going on here is that those parasites that are coming out of dormancy normally during this 2-day incubation period are restricted and prevented from coming out of dormancy in the presence of benznidazole. This cytostatic activity actually inhibits the parasites from coming out of dormancy. So it looks like you have more dormant parasites, but basically what you have is fewer that have exited dormancy. And so identifying drugs that don't have this property, that when you keep drug pressure on, you actually keep the number of dormants high, is a high priority. And here's one compound that we have been investigating that has very good killing activity against actively dividing parasites, but doesn't increase the normal number of dormant parasites that appear there. That is, it doesn't appear to have a cytostatic effect that prevents these parasites from exiting dormancy, and they're becoming sensitive to the cytotoxic activity of the drug. We can also do these sorts of experiments and look at the effect of intermittent treatment in mice in vivo. Here we've made use of light sheet fluorescent microscopy. This is a whole intact mouse heart that from a gamma knockout, interferon gamma knockout animal. So it's very highly immunocompromised, infected with 2 different strains of D. cruzi. So you have 2 different colors of parasites. And this is just to show you how we can track these parasites. In this case, a very heavy infection, a huge number of infected cells. And this is not normal. It is an immunocompromised mouse. But one can, in wild-type mice, use this same technique to identify infected cells, and again, also identify cells infected by dormant parasites using the same TD tomato cell trace violet setup. And if one, so this is prior to the initiation of drug treatment, and this is 13 weeks later. in untreated animals, you can still see dormant parasites as well as actively dividing parasites. But in this case, giving benznidazole at 500 mg per kg weekly reduces and actually eliminates all the actively dividing and the dormant parasites in this tissue. So we do believe these protocols of higher drug dose, but given less frequently, has potential to be used more effectively. You can show that in mice, actually reducing the drug concentration to 250 mg per kg, which is 2.5 times a normal daily dose, but given bi-weekly, twice a week. This is, I believe, one of the more effective protocols we have so far. Usually it cures a high percentage of mice, in this case, 100% of the mice over an 8-week period. This doesn't always work in all experiments, but it works very nicely in most experiments, and it works better than daily treatment at the standard 100 mg per kg dose. We've done these sorts of trials as well in other animals. This shows data from dogs receiving a high dose, 20 mg per kg, which is 2.5 times the normal daily dose, but given weekly in dogs. And we can see a decline in serology. So this is the treatment time point. This is 7 different dogs with chronic infections that were treated for around a 20-week period of time, 20 to 24 weeks. And then followed after that time for serology of biomarker. This is using a Luminex system where we're looking at multiple T. cruzi recombinant proteins. And essentially what we can see is just declining serology, and also all of these dogs that were PCR positive before treatment are consistently PCR negative now 18 months post-treatment, and we're continuing to follow these animals. So just to summarize, we think both the parasite biology and drug activity distribution strongly impacts treatment outcomes and should be considered when designing treatment protocols. You've just heard a talk about reducing dosing and timing, and I'm sort of telling you the opposite here, which is increasing the length of treatment, increasing dose of drug, but giving it less frequently. And so this is, again, this is what we believe works based on the biology, and happy to discuss why we think that works if it's not clear already. That these metabolic and proliferative quiescence contributes to treatment failures, and also that this may impact drugs like benznidazole that have cytostatic as well as cytotoxic effects, and that understanding more about dormancy may lead to better drug treatment options and perhaps a better understanding of parasite persistence, even in the absence of treatment. This is something that I haven't touched on today, but we think this dormancy issue may have an effect on how the immune system deals with the parasite as well. So, we think we need to know a lot more about dormancy. We need to screen for compounds that impact dormancy and T. cruzi. This is something that we're actively working on. We need more effective ways of assessing treatment outcomes. We all, I think, realize this is a problem. The fuller use of infection treatment models. I've shown you data from mouse and dogs. We also are trialing some of these protocols in non-human primates. And we think this is really one of the powerful things about working with T. cruzi, is having these other models to trial these protocols before they go into humans. And we think there can be more creativity. There's a lot of variables here that can be varied, but using the existing drugs that and understanding more about the unique biology of T. cruzi, we can be more creative about how we design treatments. And maybe also, we doubt that we really still understand all the other unanticipated aspects of T. cruzi biology. Dormancy was not something we had thought really occurred until we started delving into it. So I'll stop there. 3 Argentinians did most of the work I discussed. Angel Padilla, Juan Bustamante, and Fernando Sanchez were the primary people behind this project, supported by an excellent group in the lab, by our collaborators, Sarah Hamer at Texas A&M with the dog studies, the Microscopy core facility, and other members of the Center for Tropical Emerging Global Diseases, and the NIH and the Wellcome Trust who have helped support these studies. And thanks very much for your attention. Again, my apologies for being late, and I look forward to answering questions and hearing the rest of the discussions.
Okay. Gracias, gracias, Rick. Te perdonamos por llegar
Thank
tarde.
you, Rick.
Y vamos a ver las preguntas. Yo no puedo ver las personas que levantaron la mano. Es decir, y si no podemos ir al chat. Muchísimas gracias. Muy interesante tu disertación.
That was a very interesting presentation. I don't know whether we can see questions that were posted on the chat. I do not see them.
I think
Congratulations.
I can see them if you would like me to try to answer them. Yeah.
Janice
asks,
persistence of parasites. Is there any evidence that dormancy may favor benzoyl resistance?
Yeah, I'm sorry, can you ask that again? I thought I saw it there and then I lost it.
No, is there any possibility that dormancy favors parasite resistance? Benzoyl resistance to parasite?
Well, dormancy certainly favors, it's clear that dormant parasites are unaffected by benzoyl in vitro and in vivo. My dog is trying to answer that question as well, as you can hear in the background maybe. And as well, the reverse is true, that benzoyl induces what appears to be dormancy. It's not really dormancy, but it's an inhibition of exit from dormancy. So,
what will be your message for those who propose lower doses of or shorter regimens in patients?
Yeah, I think that's I think it's a very interesting question. I'm happy to hear the rationale for those. Besides the empirical data, I think there's a problem with the empirical data in terms of how one measures treatment efficacy, right? And I think we're all aware of that. I think it would be great if you could use less drug in a shorter treatment regimen. I don't understand the biology behind that outcome. So I'm open to hearing how the biology actually works in that case. But it wouldn't be my choice. In our hands, we have actually done those sorts of studies with benzoyl in mice, and giving lower doses over a shorter period of time does not work in the models that we study.
Amy asked if dormancy is a general phenomenon or is dependent on the parasite strain.
It is not dependent on the parasite strain. As far as we know, we have looked at least 6 or 8 different strains, different DTU types. We see dormancy occurring in all of them. We've looked at that in vitro for all of those. We haven't looked in vivo in mice at that, but it looks to be a very common occurrence in all the strains that we've looked at. And this includes not just laboratory strains, but strains that have recently circulated in non-human primates or in dogs that we've looked at as well. So these are ones that are collected recently from the field. They have the same characteristics.
We have another question from Raúl González Córdoba. He says, Dr. Tarleton, were these dormancy and activation experiments performed or will they be performed on combinations of besnidazole and nifurtimox?
We have done a number of different combination treatments to determine if combination drugs could kill dormant parasites. And there we've used 3 different drugs, nifurtimox, benznidazole, and this drug that I showed you a little bit of data for, one that we've co-developed with Anacor. And essentially what we have found is that the combination of known existing drugs that kill actively dividing parasites does not overcome dormancy. So those parasites that are dormant, it doesn't matter if you put 2 or 3 different drugs on them, they're still dormant and they're not affected by those drugs. Yeah.
Yeah. And a comment from Oscar Botasso. He says, no question, just a comment about the change introduced in leprosy treatment in the 80s. He says, current multivacillary leprosy regimen for adults consists of rifampicin once a month, dapsone daily, and clofazimine once a month, and 300 milligrams and 50 milligrams daily for 12 months. Yes, biphasic regimen, in fact.
Yeah, I think the point there is that, and it's something that we've thought a lot about, is treating chronic Pcr infection as a chronic disease, yes, and not necessarily treating it to cure it rapidly, but maybe it will take a longer treatment period. Yeah.
We will discuss it in the discussion section because this is a very interesting topic.
Sure.
Thanks very much. Treatment. So we will move to. Thank you very much, Rick.
Podemos seguir porque estamos con los tiempos para luego.
Yes, we're going to move on.
Bueno, sí. Bueno, tengo el gusto también de presentar.
I have the pleasure to introduce Dr. Diana Fabro. She works in Santa Fe, and she's the specialist in biochemistry, a researcher at the University of Biological Science of the Universidad Nacional del Litoral. She has a postgraduate degree in tropical diseases for more than 20 years. She has been conducting research and development to study factors associated to clinical progression and transplacentary transmission in Chagas disease and the evolution of possible early biomarkers regarding therapeutic efficacy and the development of cardiopathies. The results of these studies have been published in international and national journals. Dr. Fabro has focused on working on a multidisciplinary team where patients are not only analyzed from a clinical and laboratory perspective, but also analyzing the social factors that have an essential impact on vulnerable populations, including those who suffer from Chagas disease. This has allowed her to conduct many longitudinal studies in pediatric and adult populations with Chagas disease with a long interval of time and with a collection of data that is very strict and rigorous. Considering the lack of randomized long-term studies, her work has really spearheaded many initiatives to focus on randomized studies. Her work has been essential to focus on benznidazole in women of a bearing age to avoid the transmission from mother to child. She is a very important researcher in the region. She is followed by many people, so we will be hearing an interesting presentation from her. Thank you very much. Welcome, and you have the floor. Good afternoon. Thank you to everyone. And I would like to thank Adelina Riarte, thank Catalina Albasoco. Thank you for inviting me to participate in this webinar. Thank you to the SAP as well for inviting me. I am going to talk about the impact of trypanocidal therapy in children and adults with chronic T. cruzi infection followed for more than 20 years in the city of Santa Fe in Argentina. In the 70s and beginning of the 80s, we began a cohort study for children and adults with chronic infection by T. cruzi. A group of them received treatment with nifurtimox and besnidazole, and the other one was untreated. I will first refer to the changes in the ECG and serological changes as well that were observed in patients with chronic infection who received a treatment during their childhood and who had a follow-up of an average of 25 years. This is a recently published study. And for those of us who study this type of work, what we do is study those patients who had received treatment between 2 and 14 years old, patients who had a post-treatment follow-up time that was equal or higher than 15 years, and a stable residence in the city of Santa Fe during the follow-up period. We also included we excluded those children with a diagnosis of acute infection or with chronic infection, but with a risk history and a history of a risk of infection less than 2 years before treatment. We all know that with nifurtimox and besnidazole, we see a high level of efficacy in the acute phase of the disease and in the initial phase of the chronic infection. One of the main limitations that we had in our work was the creation of a control group with a similar age. When the national standards or guidelines indicated the treatment in children, all children who had remained untreated received a treatment, except those that when they came back, they had exceeded the recommended age. For this reason, we suggested including we considered a group of 15 to 25 years of age eligible, and the selection criteria I will describe in a few seconds. What we analyzed were 273 medical records, out of which 94 were children, and 51 of them were able to meet the inclusion criteria. 41 had been treated with nifurtimox 8 and with besnidazole 33. The dose of nifurtimox was 12 to 15 milligrams per kilogram per weight per day for 45 or 60 days, and the besnidazole was 5 milligrams per kilogram weight per day for 30 days. These 10 untreated children were, for the reasons that I mentioned before. On the other hand, we analyzed 179 clinical records of untreated patients 15 to 25 years old as a control group. And of them, we selected 31 patients, and the only source of infection was the conatal pathway. So they had born where they were born and raised in the city of Santa Fe, and they only had positive maternal serology. Also, those patients who had lived in endemic areas during their first 4 years of life, and then established themselves in the city of Santa Fe. We analyzed them as well. So 82 patients who were infected during their childhood, out of which half received treatment. What were the epidemiological, clinical, and demographic characteristics of these patients? Where they had to be comparable groups because the control group was already a group that started at a later age. We saw that the proportion of men and women showed no differences. There weren't any differences in the age either in the last control. We didn't observe differences in the follow-up time. And at the beginning of the study, both treated and untreated patients, two of them showed alterations in their initial ECG. The time of residence in the endemic areas during their childhood was also similar. And not only was it similar in terms of the residence time, but also the origin was the same. So all of them came from the north of the province of Santa Fe, south of Chaco, or Santiago del Estero. So the efficacy of the treatment and the clinical evolution can vary depending on the geographical area of the population analyzed. In this case, both treated and untreated patients all came from the same region, thus reducing the risk of regional heterogeneity of T. cruzi. Adverse effects, 62% of the children did not show any significant adverse effects. In the clinical records, there are no records of these serious events. And those who did show alterations were mainly digestive issues. With benznidazole, we had a much higher number of children who showed no adverse effects, but those who did report adverse effects were more severe, and some had to interrupt call because of maculopapular erythema and nausea and vomiting in 9% of the cases. When we analyze the clinical evolution of these children with a period of time, which, as I said, was on average 25 years, 92.7% of the children were able to have negative serology. That is, the patients who were treated as children. In those 15.7 plus or minus 8.7 years post-treatment, there was negative seroconversion. In untreated patients, 100% remained positive. When we use the Kaplan-Meier curves to analyze the proportion of conventional serology activity depending on the age at which these children receive treatment, we see significant differences in the probability of negative seroconversion over time in those patients who received treatment between 2 and 7 years in comparison to those who received their treatment between 8 and 14. Yes, these are the curves that show the difference. We also see this in the case that patients treated between 2 and 7 years old, 100% were CS negative, and this shows the amount of children who were treated with each of the drugs and in both age ranges. When you analyze the changes or electrocardiographic disturbances showed during the study, we had said that initially 2 patients in each group showed disturbed initial ECG. At the end of the treatment, 4 patients of the treated group and 9 in the untreated group showed electrocardiographic disturbances. But electrocardiographic disturbances there were were only observed in the untreated arm. In those patients who had received treatment, one child who at the age of 6 received the treatment with benznidazole, after 13 years of study, had a first-degree AVB. This was observed in patients who were infected with T. cruzi and also in the normal uninfected population. So therefore, this is considered an unspecific disturbance. Other studies, however, have shown a higher ABB in patients affected by T. cruzi. Since this patient continues to do checkups, we have followed up on this patient, and we observe here that 1 patient in the treated group and 4 patients in the untreated group had an incomplete block of the right branch. This is a very unspecific, frequent condition, but often it is the first manifestation of a chronic Chagas-related cardiomyopathy. They are under control, these patients. They are subject to regular checkups, but of course, we have to analyze whether this will move on to be a specific Chagas-related condition. A logistic regression analysis of variables independently associated with the occurrence of electrocardiographic abnormalities. This shows that the probability of developing electrocardiographic disturbances is reduced significantly because of the treatment. We can also say that the treatment with nifurtimox and besnidazole was well tolerated by children. Zero conversion was highly observed, and only one of them developed mild heart conduction disturbance during the 25 years of follow-up. I will now refer to the efficacy of treatment in adults with chronic infection. These patients were in the undetermined phase or with no shown pathology at the beginning of the study. In the year 2007, we did a publication with a mean follow-up of 21 years. In this study, we observed that 37% of the patients were able to have negative seroconversion, and we saw a clinical evolution that was favorable after the treatment. We also observed after 30 years of follow-up that out of 492 medical records in adult patients, we selected patients who were between 15 and 49 years old with a follow-up higher than 20 years, and all of them resided stably in the city of Santa Fe. These requirements were met by 125 patients, but 12 of them were excluded because there was an initial altered ECG. So we studied 113 patients with normal ECG at baseline, out of which 52 received the treatment, 24 with nifurtimox and 28 with benznidazole, and the therapeutic scheme were 8 to 10 milligrams per kilo per day over 45 and 60 days for nifurtimox, and for benznidazole 5 milligrams per kilogram of weight per day over 30 days. 61 patients remained untreated. The adverse effects were here. 62% of the patients treated with nifurtimox showed no significant alteration, but those who showed adverse effects were mostly digestive. In benznidazole, the percentage of patients showing no adverse effects was higher, but those who had adverse effects, they were more severe, to the point where 4 patients had to discontinue due to pruritus and maculopapular erythema. Patients treated with nifurtimox, 1 patient had to stop due to vomiting, and 2 patients had xenodiagnosis after finishing the treatment. Those patients that had to interrupt due to intolerance, or these 2 patients where there was a therapeutic failure, were treated with the other drug. Yes. So it was there was intolerance to benznidazole, nifurtimox was administered, and this is what we considered in the evaluation. The age group was quite wide. It was 15 to 49. So that's why we divided it, because this has an impact in the development of cardiomyopathy. So we wanted to see if the untreated and treated were the same in the age and in the follow-up time. So we saw that they were similar. Actually, there are more young patients in the untreated group, and in the older group, it was the same number. We did not observe differences in the follow-up time, not between the age groups and neither between the treated and untreated groups. The final average follow-up time was 30.2 plus minus 5-6 years. So the total is that. Then we have it divided between the treated and untreated. We saw the negative serological evolution here, 67.3%. In the case of nifurtimox, it was 66.6%, and benznidazole was 67.8%, and 15.4% showed indefinite serology. So this means that these patients in some checkups, in some controls, the 3 serological tests, which are the 3 that we always conduct on all patients, were negative. But in later controls, we saw a slight reactivity in the value. So they weren't clearly positive, but sometimes in one of the tests or in two, this appeared in some of the tests. So that's why we didn't include them as the group that we consider persistently negative. This other group showed positive serology, 17.3% remained positive. And in untreated patients, 100% remained positive in all 3 serological tests. So we did not observe spontaneous negative seroconversion as reported in other studies. Once again, using Kaplan-Meier curve to demonstrate the proportion of CS reactivity over time according to treatment initiation age. What we see here is that there are no differences between patients who received treatment when they were between 15 and 30 and those who received patients at a later age. This is different from what we've observed in children. So the probability of having a negative seroconversion is similar regardless of the age in which the patients receive treatment. However, when we analyze the proportion of reactivity of conventional serology, in this case, seeing the drug that was used, we see that both in the case of nifurtimox and besnidazole, we saw similar values. It's almost 0.8. So there isn't really much of a difference. With respect to the electrocardiographic disturbances observed in the study period, the inclusion criteria was to have a normal ECG. So during the study period, we observed that there were disturbances compatible with chronic Chagas disease. And here, 2 of them showed, in addition, associated pathology such as obesity and diabetes and severe hypertension, and the age has to be considered as well, where these disturbances appeared. In the group of patients who did not receive patient, 15 of them developed disturbances associated to Chagas-related cardiopathies. And we saw as an associated pathology, we saw hypertension as an associated pathology. These were the patients which showed a significant level from a clinical perspective. Here we saw a higher rate of negative seroconversion within a longer period of time. It is very important to take into account the limitations and the potential biases included in this study. This is an observational study with all the limitations that observational studies have, of course. And also the small size of the sample. As we become more selective, the conditions to have easily comparable groups, of course, this reduces the number of patients. And cardiac involvement evaluation was done through an ECG. Although the ECG is not sufficient in itself for a full assessment of cardiac involvement, this was also a very useful tool that could be used in all patients in each of the controls. Also, patients who had an altered ECG used to have to take an EKG, and now this work continues, and we have also started to ask for a chest X-ray. This is what is done in the hospitals of our city. So going beyond limitations or possible biases, which are important to mention and must be considered, these 195 patients that I have mentioned in these works all remained in the city of Santa Fe during the study period, And this is an area with not a very high risk of vector infection. And all of them live in neighborhoods with access to clean water, health, and education. So all of these are the results. So we can say that the treatment with 30 days for benznidazole was sufficient to achieve the serological cure in a high percentage of children and adults, and that the tolerability level of NFX was slightly higher than the BZL, while the efficacy profile of both drugs did not differ.
Require greater evidence and observed findings for over 2 decades of follow-up indicated a better clinical evolution in children and adults treated as compared to those that remained without treatment. Finally, I would like to mention my appreciation to professionals, teachers, and investigators from the Center of Research on National Endemics who took part in these efforts, without whose valuable collaboration it wouldn't have been possible to achieve set out objectives. These are their names. Thank you.
Bueno, muchas gracias, Diana, por tu presentación y
Thank you so much, Diana, for your presentation. We remain open to questions.
yo de momento te quería preguntar una cosa, Diana.
I wanted to ask you the following, Diana.
Tú hablas de que los pacientes que
You talk about the fact that patients you followed up on, or patients that were followed up on, always lived in the city of Santa Fe. This means that they didn't get reinfected in a vector transition area. Why do you underscore this? Why do you highlight it? Why did you think it was this way? This was a patient inclusion criteria. Patients who traveled to risk areas, well, we excluded them from that work. This is one of the reasons why the number of patients was reduced. We suspected this, and in order to assess treatment, if they go back to the vectorial treatment area, we have high risk. On the other hand, patients who did not receive treatment, a potential reinfection, even though in the last few years we had the province in better conditions, but that is only in connection to the risk of vector infection. But in any case, these trials that have been going on for so long had a different situation. I underscore this because of this reason. We want to make sure to reduce or avoid the risk of reinfection. Do you think that people who acquired infection and who remain in urban areas have a difference in the clinical population? Is there less clinical progression? We haven't done comparative trials, but we are based on other trials where those that have carried out this research, they claim that the risk for developing cardiopathies is bigger among people who are exposed to reinfections. We haven't carried out comparative tests because we have always worked with an urban population. This is why I underscored towards the end what the characteristic was for our population, so that we can analyze or have well compared parameters. We do not work in an endemic area. Is your microphone muted? Ade?
Trataron entonces, vos no encontraste diferencias, digamos, entre los
Did you find differences between or among the different ages in connection to the serology negativization of patients, whether they are 30 or 40? There was no difference in the serological impact. The question I ask you is, in the time that the patients spent with you, are you able to determine what the time was where patients progressed? when they were under your control? Was it 1 year? Was it 5 years? Because all the patients, based on the classical terminology, they were healthy patients, infected by healthy, that is, indeterminate patients. So how long did it take patients to progress? Because they were all patients that did not have proven pathology or demonstrable pathology, as we say now. Well, the time got to vary. We were able to establish that the age of onset of lesions, of cardiac lesions, was the one we mentioned. The time was variable to such an extent that there's 2 patients in the treated group who 2 years later, they started having electrocardiographic alterations compatible with Chagas. They developed cardiopathy, and this is why I highlighted that we used the AKG as the only way to assess these patients cardiacally. So these alterations would have been detected earlier on. But by and large, the age of a lesion onset vary a lot. I could talk about the time. Time varies a lot. It depends on the age of patient's admission and for how long they were kept under control. The age of lesion onset in the populations that I have just mentioned is about 40 years. These patients, were they serologically negative? Were they unspecified or positive? There are serologically negative patients who progressed, serologically negative patients who progressed, and these are patients who were negative soon after. Soon as you find the AKG alterations, their serology was positive, but they went negative and they developed a chagastic cardiopathy. There is a question by Faustino, Torrico, and Esther. Faustino, please take the floor. Thank you, doctor, for this wonderful presentation and also for the time of follow-up, 30 years. This is an example of hard work. Let me ask you something quite simple. You have carried out the zero negativity by all 3 tests, and did any one of them go negative sooner than any other? Thank you, doctor. We have always carried out these serological tests. We did not see an earlier seroconversion with any of the tests. They got to vary over time. Of course, these are the serological reactions, but reagents changed. In order for us to avoid or to make sure that we were working on the same conditions, we preserved serum samples that we have, frozen serum samples, and over time we carried out this with the new tests to see whether we would have the same response that we had at the control moment. We carried that out when we want to use these specimens in order to carry out marker trials for early markers of the therapeutic reaction or of pathology. There was no test that would go negative before. There are fluctuations. Some go negative sooner than others, but there is no single one that will always go negative sooner. The 3 tests that we used, well, initially, direct agglutination, hemoagglutination, and immunofluorescence. We then incorporated the ELISA test. And as time went by, we included new tests. For that reason, I say that in our case, in order to ensure that this negativization is for real, it is not that we are changing reagents. This is why we compare against the serum samples that we had frozen. Oscar, thank you.
Oscar, ¿ibas a hablar? ¿Estás con el micrófono?
Oscar, were you about to take the floor? Is your microphone muted?
Está otra vez muteado.
¿Se escucha ahora?
Sí,
Bueno,
adelante.
le cuento un estudio que hicimos en la época de los
I
años
will
80.
talk about a trial that we carried out in the 1980s. We had a big migration from people from Chaco to Rosario, and they carried chagas behind their backs. So we said, let's go look based on how long they have lived in the area of high endemicity, because they would always stay in Rosario, eradicated. So we had people that had come from Rosario, being 5, some had lived in the endemic area, being 10 or older, and some had come to Rosario in their 20s. So they all had then the same ages, they all were factory workers, so as not to have so much systematic error in the middle. We saw that people that had lived for longer in the highly endemic area, comparing those that were 15, that had lived in those places 15 years or longer, rather than those that migrated being younger, had more alterations on the AKGs. I'm not saying they had severe cardiopathy, but they did have more marked alterations. The population was relatively young. These were young adults. What happened to them later, I really don't know, but everything seemed to indicate that it is not good to live for too long in the middle of an area of endemicity and coexist with this, bug, what we call locally the Venchuca. That was issued in at the time when I was really young.
Gracias, Diana.
Bueno, ¿alguna pregunta más?
Any other question?
¿Quedó alguna pregunta?
De esta sección no.
Not from this section.
Vamos a iniciar son las 17:16.
So it's 15 past 5. We can open up to the broad discussion to all the speakers, Rick, Faustino, Diana. All questions can be addressed to all participants. I see that some questions were unanswered. They are outstanding. I see them here. So we can talk about them, and then you can still keep raising your hand. Catalina, we can ask them together. I can get started here. These are the pending questions.
Primero las de Julio Urbina. Gracias, Julio.
Julio Urbina, thank you so much for participating. I remind you that you can raise your hand so that it is asked orally. Julio congratulates Faustino for the excellent presentation. Best wishes for the 36-month follow-up that will help find out whether the reduction of the parasitic load will be substantiated over time beyond the clinical trials. And the results of a trial so suggest so, but the follow-up of patients was not rigorous. Dr. Yanis, what is the message to those that are suggesting low doses, shorter schemes of treatment among patients? Who is this question addressed to or directed to? I really don't know. This goes to Rick. Are the dormant parasites immunologically competent? That question goes to you.
Yes. So I guess the question is, are these dormant parasites recognized by the immune system? That's a great question. It's something we have been investigating. One interesting thing we've seen is, so it's a difficult thing to assess because detecting dormant parasites in an animal is not simple. But interestingly, what we find is that even actively dividing parasite infected cells are not uniformly recognized by the immune system. So, so even if the parasites are non-dormant, it's not a given that the immune system detects those, at least in the mouse. So this is an interesting phenomenon in itself, but our suggestion is that dormant parasites are likely not recognized by the immune system, at least very efficiently. But we really have very, very little data on that because of the difficulty in accumulating that sort of data.
Hay una pregunta, un
There
comentario.
is a question or a comment on the part of Dr. Gerardo Mirkins. This is addressed again to Rick. He appreciates your presentation, Dr. Tarleton, and he has a question in connection to exit from dormancy and treatment. Could the treatment enable exit from dormancy, enabling parasites to invade other tissues in spite of high doses?
Yeah, well, so presumably parasites that exit dormancy, they assume a normal replication cycle, and those parasites released from cells would potentially infect other tissues. But if you, I mean, one of the points of doing like a twice weekly treatment regimen is that if a parasite comes out of dormancy, it will take 4 to 5 days for parasites to exit from that infected cell. So presumably there would be drug around at some point during that period of time if you're treating, say, twice a week, so that those actively dividing parasites are now sensitive to drug. Of course, any parasite that's exiting a cell as a triple mastodon is capable of infecting another cell, and if there's not drug around, they're likely going to be successful doing that.
Cata, ¿le puedes dar la voz al
Cata,
doctor?
can you please give the floor to Dr. Yanes? We will read one question that has been written and then give the floor to an oral question. Dr. Yanes asked for the floor.
Sí, esto es una pregunta un poco.
Well, this question has to do with the context. As we all know, with COVID, there has been a great awareness on the part of people of the risk-benefit ratio of interventions. We've seen a vaccine that has expressed adverse effects that were quite odd numerically, and they determined people to refuse to get immunized. Of course, before COVID, pre-COVID, what we expert physicians considered as adverse effects, we talk about tolerated or non-tolerated effects. So my question is, do you believe that this awareness of risk-benefit ratio that has happened with COVID has or will have an impact on treatment acceptance on the part of those who haven't made up their mind when treatment is offered to them and when they are claimed to have high risk potential? How is the context of COVID experience among patients going to influence, treatment programs?
¿Alguien puede contestar?
Can anyone reply?
Faustino.
Well, it's a trial of an answer. It's almost some forecasting that has to be made here. Evidently, there are increasing anti-treatment groups around, and these anti-treatment groups, regretfully so, affect the populations that are affected, the poorest population that are affected by Chagas, because they grab this discourse, they are filled up with fear. So it could have some sort of influence because of the context, the social context, I mean, that makes fear grow among these groups. So there will be some effect. There will be some effect On the contrary, we on our part, in the patients that we have treated and that we are following up with Chagas, we have the treatment proposal or a vaccination proposal for COVID. That's a very important act. And we have kind of 75% of people who have accepted to get immunized because of how good it is. But the group in the general public, it could be a little bit more complex. There is a question addressed to Diana. Those that progressed, were they seropositive? They did receive new treatment when the alterations appeared.
Diana.
Estaba muteada, perdón.
Diana, sorry. Yes, I was on mute. My microphone was on mute. Yes. Patients who had an electrocardiogram disturbance did not receive another treatment. We just indicated another treatment in the case of discontinuation because of intolerance after maybe 15 or 20 days. We started with the other drug, or in the 2 cases of therapeutic failure. But those patients who evolved towards a Chagas-related cardiopathy did not receive another treatment. Actually, as I said before, some patients were able to have negative seroconversion. Not all of them, but they were able to have negative seroconversion, some of them, yes.
Sergio Sosa, que te lo comento, Diana. Felicitaciones
There's
a Diana.
A comment from Sergio Sosa. Congratulations, Diana and team. Another analytical approach would be to not exclude those who travel to risk areas and do sensitivity analysis of the effect, including and excluding those who travel to high-risk areas. It's just a comment. Yes, thank you, Sergio. That is true. And that's something that we have considered. But right now, we have them selected with this criteria. We know of patients who have traveled and who continue to be controlled, so they continue to attend their checkups, and so we can do that study. So thank you. Thank you, Sergio.
¿Hay alguna pregunta? ¿Alguien con la mano levantada?
There are people with their hand. I wanted to ask a question to Facundo, to Rick, and to Faustino, actually to all 3 of them. I wanted to know about the PK of benznidazole, if there are specific studies on that, because I think this is what will validate intermittent treatments, weekly or biweekly or not. Facundo, for example, do you think that benznidazole adjusts more to a maximum concentration model, or rather a model where you will need to do like a constant administration to reach levels in plasmatic level above the average? I mean, what do you think that adjusts better in terms of the PK? I think it's more for Rick than for me, this question, but I think it depends on the cycle, I think, of the parasites. I think that the PK of benznidazole is relatively similar. We do not know about the metabolites. We don't know about the effectiveness of the metabolites, and this probably has more to do with the adverse effects than with the PK. But honestly, PK, especially in adults, is a very simple PK. It has a simple, I mean, it arrives at the tissues. So if this were an antibiotic, it would be great, but the problem is that it's not. But so it's more complex than that. So that's where the doubt appears. What is the relationship between the concentration in the tissues and the life cycle of the parasite? This is, I think Rick can answer this question better.
I think if you're dealing with the actively dividing parasite, it is fairly simple. It would work great if it was a maintained level over time, but that's not the case. And you're also doing what I was trying to emphasize as well, parasites that are in different tissues where the drug concentration reaching those tissues is different. So I think, very early on in treatment, having a high level continuously to quickly drop parasite load makes a lot of sense. But once you do that, and you have parasites left in certain tissues where drug concentrations don't reach, or dormant parasites, then a higher drug concentration, so a maximum dose rather than a continuous dose, makes a lot more sense. That's, just empirical findings. We don't have the data where we've actually looked in those tissues to look at drug concentrations or even try to monitor parasite numbers in those tissues. It's a very difficult thing when you're dealing with such low numbers of parasites, and the dormant parasites even lower than just total parasites. So that's a great question.
Y en este camino, ¿hay alguna otra pregunta?
In this exploration road, I think that we need to develop, maybe Rick or Facundo can maybe help us, because 500 milligrams per day, it seems to me like too much. I mean, we have done our treatments in many patients, and the arm that received benznidazole were more than 350 patients. And actually, we do not have a fixed dose. I know that then we had an empirical recommendation from the group of Brazil of 300 milligrams per day, and then we gave a dose adjusted by weight. And we haven't had more adverse effects in those who received more, actually, but it was more like personal, susceptibility. We've given up to 400 milligrams, for example, in a patient who weighed 80 kilos, but 500 milligrams seems to me like something that we need to continue exploring, no? Because Rick, you've presented the possibility of 250 to 500 in an intermittent manner in your model. And in the work that was presented by Rodolfo with Marina, and who presented this as well, talked about an intermittent doses that was more like regular, more common. I think it was like 300 milligrams. And I think this has proven useful, but this intermittent approach did not last more than 2 months. So what do you think, or what would you consider, how would you consider this from a pharmacological perspective, to have this intermittent approach, but for longer, where one could access those dormant parasites for longer time? So giving a doses like a more regular doses, yes, because I think Rodolfo and the team at the hospital were like regular doses, which I think it was 300 milligrams in total, but in 12 doses every 5 days, and during 2 months. So what would you think about this? How would you approach this? Maybe, but exploring the possibility of not doing it for 2 months, but for longer. Because we are evaluating this from a serological and parasitological effect, but the point here would be whether one could have another approach from a clinical perspective. I think this constitutes a bottleneck, a critical bottleneck in clinical trials.
Si Faustino quiere hablar primero, perdón.
O Faustino.
I don't know who wishes to answer.
Preguntas para Rick.
Well, I have some questions for Rick as well, so. But is it about this or about something else? No, it's about the same thing, about dormant parasites. So let's see.
Well, so maybe maybe I could clarify the dosing here. When we're talking about 500 milligrams per kilogram in the mouse, that is a very different dosing than in humans. So that's 5 times the normal daily dose, right? Which would be comparable to, say, 25 to 30 mg per kg in humans, something like that, right? So that would be the maximum dose. But again, it's given not daily. It's given, in our case, the best outcomes have been twice a week dosing at 2.5 to 5 times the normal daily dose. whatever the species is. So when we're using mice, non-human primates, and dogs, the results are very similar. If we give intermittent dosing at a standard daily dose, the 1x dose, so that would be 5 to 8 mg per kg in humans, we don't see that working very well intermittently in the mouse system. We haven't tried that in other models, so I can't really comment on whether that might work well in non-human primates. In terms of length of treatment, I totally agree with you. So we can treat 2.5 times the normal daily dose once or twice a week for 6 months, and we've given essentially the same amount of drug as if we had treated daily for 2 months. So if toxicity did have some cumulative effects, Faustino's data suggests that that's not the case in most situations, that most of the toxicity is occurring very, very early on. That if it did have a cumulative effect, then that, the total drug amount isn't really increased by extending it over a longer period of time.
Ok. Vos, Facundo, ¿tenías algo que decir?
Facundo, you had something to add? From the more clinical perspective, I think that it depends on how much you can give the first doses. It obviously has a lot to do with toxicity, because what changes is whether you can give the whole doses in 1 week in 1 day or divided. But the only thing that will change is the difference between the peak and the trough. So some of the toxicities seem cumulative. For example, rash or other more severe toxicities are immunological in their basis. And so probably they will have a higher or lower peak, but that will not change significantly. The intolerance in the digestive tube or headaches in general, that seem to have a stronger relationship with the peak. So if you give a higher dose every few days, maybe the patient will have a headache every few days. But the truth is that we don't have a full picture between this and then the toxicity. This should be further explored, I believe.
Hay algunas preguntas. Vos podés hacer una cosa muy corta.
Can we do something very short? Faustino, what you wanted to ask? Yes, please, very short, because we are exceeding our time. It's a question for Rick. If I talk about these dormant parasites, I think it's extremely important for the future of our treatments in general. And I wanted to know, how long are they dormant? Because this makes me think about the bee bugs, that can sleep for 30 years. Yes. So, I mean, what wakes them up? What is it that wakes them up? Because we've seen that some treatment helps them sleep longer, but what wakes them up? And the other question is, does it depend on the host? I mean, a mouse, if the mouse is a host, is it the same as in humans? Is it the same in dogs? I mean, this dormancy, that's what I wanted to know. Thank you.
Yeah. I'll try to answer that last question first. So we know that dormancy exists in vitro and in vivo and is independent of cell type. We haven't studied dormancy in humans or in dogs. Difficult to do in both of those cases. So in an animal, the only data we have is the mouse. So we assume that it happens in mouse, it happens in every cell culture, it happens with every strain that we've tested in. So we assume it's uniform in different hosts, but it's possible that it's not. Remind me again what your first question was. Sorry, I forgot it already.
How long they remain dormant?
Oh, how long do they remain dormant? Yes. I think it's highly variable. I tried to show you some data there that some come out of dormancy within a 24-hour period, I think the point, though, is that this isn't something that occurs just once during infection, that every time parasites infect a new set of cells, some of those parasites become dormant. So that's being repeated over and over again. So as long as you have actively dividing parasites, you're going to have new dormant parasites, right? So a drug treatment that, like benznidazole, that very effectively kills most actively dividing parasites is going to reduce the number of new dormant parasites, right? So let's assume that you complete, keep that actively dividing ones under wraps, right? And so the only thing that has to be dealt with is ones that are coming out of dormancy. And then we don't really know. We know that in vitro and in vivo, it's at least 20 days in some cases, 30 days in some cases. Could it be longer? I don't know. I think the key here maybe is not trying to figure out, because it seems to be sort of stochastic, and it may, I would not be surprised if it varies with different tissue types, for example, that if parasites are in certain cell types or certain, in fat versus muscle, maybe dormancy patterns are different. Who knows? But I think really what we need is to understand what your other question was, is what wakes them up. It's clear that they are not totally absent of sensing activity. There is some activity there. So I think the real key to this will be to identify compounds that may wake those dormant parasites up. And then you may have a treatment, you may be able to treat with benznidazole in 5 days versus 5 weeks or 5 months. If you have something that really brings all the parasites out of dormancy so that they're all equally affected by a very highly cytotoxic drug like benznidazole and fluoromonas. And that's something we're very actively looking for, is screening for compounds that reverse dormancy.
Bueno, nosotros vamos a tener que cerrar porque.
Thank you very much. This is all the time that we had. 5:45, we have to close up, but I will be giving some closing remarks. First of all, I would like to thank you very much. Thank you, Facundo. Thank you, Faustino. Thank you, Rick. Thank you, Diana, for the presentations. And I think it would be very interesting to continue this discussion. It's impossible to take more time, but we have 13 questions that have remained unanswered, but we are going to send them out. So maybe you can provide the answers to all of those who have asked questions, but who unfortunately were not able to ask them live. I would like to thank you very much for the high quality of each presentation on behalf of the SAP. And now I would like to just recap and do a closing of all of this. Thank you very much for the quality of all the symposium and all of the presentations.
Can you see? Is the size good enough? So we are finalizing the symposium that, well, the title here, we have worked with presentations. This is how work was done, working harder and making better novel insights in the biology and treatment of T. cruzi infection. On behalf of the Argentinian Society of Protozoology, we thank our speakers, our special guests, especially the ones that have been here on board, but those that we invited, as Yanis Lasvin and all others, and all of our partners who are part of our society for their presence in this symposium. A few comments on what was expressed in this symposium to underscore the biological capacity of T. cruzi to be in a quiescent stage that, similar to other pathogens such as TB, Leishmania species, HIV, and others, that make them insensitive in a transient manner to the drugs in use. This opens up a path to treatment protocols that are innovative, that should be considered and explored. That have to be considered and explored in future clinical trials. Knowledge on the PK and PD of drugs commonly used in Chagas disease, such as benznidazole and nirfutumox in children and adults, is partial, and it dates back from recent years. Pioneer studies from way before, but more recently, from Facundo Garcia Cornicen and his team, Jaime Altrich and Hector Freilis, determined that lower concentrations of the drug on plasma of children revealed that there is quicker clearance in connection to adults, and the children respond better to the drug with far fewer adverse effects. A comprehensive understanding of benznidazole and nifurtimox is urgently necessary when designing the new effective treatment protocols. The Bendita trial shows two important subjects for us and two important goals: low-dose regimens for treatment and different times of administration that are targeted to two big challenges in Chagas disease. On the one hand, to have trypanocidal effects and fewer adverse effects that, for us as a society, are achievements. Achievements include managing access to treatment so that doctors can lose fear, can do away with fear against treating. But what about the bottlenecks where we need to keep bypassing? Bendita and other studies with a similar rationale fail in detecting clinical outcomes, and this should be borne in mind. For instance, the non-progression of the disease constitutes, and let's remember this, the true cure of patients. Access is very important, but the true cure of patients and determine the non-progression of disease is also very important. Further evidence is needed for the use of qPCR as a surrogate marker of parasitological cure. In addition, patients with positive serology but negative to PCR at baseline should not be excluded from trials. We should look for other alternative ways of how to include these patients and other alternative ways where measuring qPCR to be included based on other measurement mechanisms. Our attempt is to try to fill out this lack, determining a cure or to surrogate the parasitological cure. A retrospective cohort of 82 patients treated with benznidazole and nifurtimox before 50 years of age with a mean follow-up of 25 years showed trypanocidal effects by negative seroconversion and low clinic progression on treated patients. This reinforces a concept that childhood should be the age of choice for specific treatment. The clinical trial in adults who were treated with nirfutemox and benznidazole with 21 years of follow-up showed trypanocidal effect and clinical effect with less clinical progression among treated patients. This result produced an indelible mark on the direction of randomized clinical trials. How can this be possible? through strong collaborative efforts among groups are needed to demonstrate this clinical effect due to the fact that the necessary number to treat in order to decrease one clinical event in urban areas is increasingly higher. We would like to thank also all of those who have cooperated with this symposium, speakers, experts, friends, partners, and our society. We would like to also thank CONICET and Healthy World Mundo Sano, who have been pivotal supports for this symposium. You are awaited in Mendoza. Thank you so much. Thank you. That was very kind of all of you, and greetings to you all. Good afternoon.